let me see. Hello, Dr. Imran.
Hello, hello. How are you?
How are
Can you
you?
hear me?
Yeah, I can
Yeah, I'm
hear you.
fine.
Thank
Yeah,
you. Can you see my
yeah.
can you see my video?
Hello.
Uh,
Hello.
Hi.
Hello, Dr.
I
Ahmed.
can't see.
How are you?
I'm fine. I'm fine.
I'm good. And
Happy
you?
to see you, my
How are
friends.
you?
Thanks for coming on time and thanks for your dedication to the show.
Thank you for the invitation. I'm very pleased and honored to be part of this
Thank
program.
you. It is our pleasure, and I'm going to tell you that this is the second program of the Endo Leader Show. Endo Leader Show is actually a platform that is going to create a community with different endodontics from different countries around the world, and we try to actually have different programs about different subjects in the field of endodontic treatment, and we want to promote our field of actually dentistry and practice. Thanks for accepting our invitation. So happy
Yeah,
to have the chance of meeting you
yeah.
from actually Doha and from India. Uh,
Okay. Uh,
thank you, thank you.
Thank
Tell
you,
me what,
Dr. Ali.
thank you. Uh, Dr. Imran, which city is now you are living?
Yeah. Actually, as you know, India is the very big country, and
Yes.
in India there are different states, and in that there is a big state, one of the biggest state, that is Maharashtra. In Maharashtra, you might be knowing about the Mumbai, right? So
Yeah, Mumbai. Yeah.
just, yeah, you can simply
Yeah.
consider just near 5-6 hours from Mumbai, there is a beautiful town called as Pune, and in the Pune district I stay, and from there only I work. I have an academy there and a clinic over there, so I run my clinic over there, and I work in the same place.
Very good. I'm very excited to actually have a
Exactly.
chance to
Yeah.
meet you.
Even
Yeah.
I am very excited to share all the clinical tips and tricks about the complex cases, what we deal here, and anatomies, what we face here in India, especially the rural India. And, I will be glad to share with the people of Iran, with the people of Iraq, with the people of even all the Gulf countries and the people who have joined from all around the globe. So it will be pleasure to present my short webinar or short slides. So hopefully the people will learn a lot and they will enjoy this discussion and the cases also.
Uh, Thank you. I just want to ask you, give a brief explanation about your academic actually history or
Yeah,
anything you want to tell about
yeah,
yourself, about your
yeah,
journey to the
yeah.
endodontics.
Yeah, actually, I started my journey in 2016 as a student. When I passed out, I was highly interested in the subject of endodontics. Then I started my journey from there. And after learning and going through a lot of educational courses and studies, I came to know that this subject is very vast and very difficult to understand, especially for the beginners, because as you guys know, the structure of endodontics is not so strong yet in all around the world, especially in the subcontinent, in my opinion. So, how we can simplify this to the people, especially to the beginners? That was my motto, and this is how I started. And in 2017 and 18, I started my clinical practice along with an academy where I keep long-term courses and short-term courses together. So this is how I started, and today I'm here with you. And hopefully, it's a pleasure to even join Dr. Ahmed Sayem also, and you, Dr. Ali. It's a pleasure that you guys have invited to the Endo Leaders Show. Definitely, I will try my best to those who are joined from all around the world. I will try to simplify the things, and they will learn a lot through this Endo Leaders program. I'm really happy that the people, those who have joined, and hopefully will continue within another 3 minutes, right? Those who have joined, please invite the people and your friends, because this will be the completely game-changing webinar about the anatomic
Exactly.
challenges. As I am very much excited about to share the special tricks and tips which are quite hidden around the uh, special complex anatomies. And definitely will together we are going to simplify these things for the people and the audience, those who are there, especially for the beginners.
Thank you. For your complete explanation. It is an honor for me that I have the chance to meet
Thank you.
you. Okay, Dr. Ahmad, it's your turn. Please go on.
Okay, first of all, thank you so much for this invitation. It's a pleasure meeting you, doctors, and thanks for everyone who is watching us and following us in the Leaders Show. Okay, I started my journey in Egypt in 2010. I did my bachelor degree in Cairo University in Egypt. And then I moved to Spain to do the master degree, and then I moved to Qatar. Actually, I was born in Qatar, and then I moved back to Qatar again with my family. I work for Platinum Medical Center. It's a private clinic based in Doha. Yeah, I work as an with a microscope, high technologies like intraoral scanners, CBCT, and today I would like to show you like an interesting cases using all those technologies together, using the CBCT intraoral scanner together with root canal
Thank you. Thank you. It
treatments.
will be an interesting discussion with you guys. Dr. Ahmad, will you come with your actually EndoGoat page to the show or no? No, because you asked me if
Yeah,
it is possible to come with
yeah,
that. You are free. If you have come to the actually live, I will invite
yeah.
you.
I can go out and
You can use your laptop
let me
if you want.
check
Yeah,
if I can open from my laptop. Yeah. Okay, 1 second, please.
let's check if it is possible to have you with your other interesting page. I really like your page named EndoGoat.
Thank
Yeah,
you so much.
you have shared different interesting and complex cases from different endodontists around the world, and it is a very good platform for all the endodontists around the world to have actually a good motivation to share their cases, and they will be chosen with your page. You're welcome.
Thank you so much. Just give me a few seconds, please.
No
I'm
hurry,
just
no hurry.
trying now
There's no
to
rush.
connect.
So I am very happy that Dr. Ahmed has joined, and I am very much inspired by Dr. Ahmed's journey. And as he said, at the very young age, the guy has done a PhD, and I'm definitely in the afternoon also we had a conversation about it. And I'm very happy that he's going to share the great ideas about his cases. And it's an inspiration that such a young guy has done a PhD in the subject. And for all the youngsters, those who have joined, please invite your friends and colleagues, because this discussion is definitely going to help all of you. And even the great clinician from Qatar, Dr. Ahmed, has already joined. You can see his page also. The great cases are full over there, and he's also, as you guys know, exclusively working on a microscope, and gaining knowledge from such people who have came just for the purpose that people should learn something. You should not miss it. Please invite your friends and colleagues, and I would like to invite Dr. Ahmed also to India someday, hopefully, and even Dr. Ali. Both of you
Thank
are
you.
most welcome in India, and definitely will plan something in India soon.
Yeah, I want to find the free time
Thank you
that
so
I will
much.
find the chance to travel to your countries, and I want to meet you and actually visit your country because both
Yes,
of your
most
countries are
welcome.
beautiful. Yeah,
Most welcome, most welcome.
thank you, thank you.
It's gonna be our pleasure.
Thank you. I
Welcome.
have actually
I'm
recently I
sorry.
have read a chapter written by Dr. Ahmed. It was very interesting for me. It was about the modern concept of endodontic microsurgery. It was actually a very good chapter written by him, and I was very impressed about the details and all the new actually advancement in the field of endodontic microsurgery that was in that chapter. And I really suggest all the audiences
Thank
and
you so much.
participants
I'm
to
glad.
read that chapter if you're interested in the field of actually microsurgical endodontics.
Okay.
Thank you so much. I'm glad that you like it. And if anyone is interested in reading that chapter, I can forward you the chapter. Just text me on my Indigo page or on my private account. I can share with you the chapter without any. You are very, very welcome, and I will be very pleased to have
Thank you.
your
Thanks for your
feedback.
generosity towards sharing your knowledge and your actually works.
Thank you. Now I can. I just opened the Indigo.
Okay. You can come to my page and you will see my notification that I have started the live, and then you can join.
Yeah, I
Yeah, I
can
see
see
you.
that
Let
there
me
is
ask
a
you to
live.
join
Yeah,
with your EndoGoat page. Happy to have you with two pages. We can see you from two different cameras.
yeah, yeah. Me too.
Okay. Let me, I have invited you again.
Okay, because I cannot see any invitation yet. Let's see again.
I just sent you the invitation. If you can see it, please tell me. Okay, Mr. Dr.
Yeah.
Imran, you can
Yeah.
go
Can
on with your cases.
can I?
I will,
Yes.
yeah, yeah,
Yes. I will continue first. So after me, Dr. Ahmed will explain
yeah,
you. I will not take so much of time, but within short time, I will try to cover the important aspects, and I am gonna present myself. So I will directly go to the screen. That will be better, I think.
Okay, okay, thank you, thank you.
Okay. Okay. So I am just turning the camera to the screen. Hopefully, you guys can see the screen very clearly. Is it clear?
Yeah, exactly.
Yeah,
It's
Just a
clear,
yes.
thanks.
second. Yeah, just a second. Yeah. Hopefully, the screen is clear, right?
Yeah, it's clear.
Yeah. So, see, I welcome all the people, those who have joined from the Middle East and subcontinent, especially from the India, from the Qatar, from the Iran, and all around the globe. I warm welcome to the live organized by the Endo Leaders Show, and we will directly start with our presentation. It's a short presentation. I'm not going to consume a lot of time, but within this short presentation, I am definitely going to cover the best topics and the most highly trending topics because that is very important. So, as you guys know, endodontics is all about cleaning the root canals. So, as you guys know, this guy is a very famous scientist, Albert Einstein, which has a very simple formula: E is equal to mc square. Endodontics is equal to making canals clean, as all of you know it very clearly. Second, as you guys know, as our topic for today is complex anatomies, or what you can call it as anatomical challenges. Anatomical challenges, even as you guys know, we have a three-dimensional root canal system where the files cannot reach, especially in the areas where isthmuses are present. So we have to always think about the activation and irrigation of the root canal system. If you irrigate it copiously with safety, that will be very, very important for you guys to clean the root canal system. If you clean the root canal system well, definitely you get the best result.
Dr. Imran, can I ask you to move your camera further from the actually your laptop because it will let us to see the whole screen of your laptop.
Okay.
Move it,
Can,
yeah,
can,
go
can you please move?
a bit further again. It's now better. Yeah, it's better. Yeah, it's better. Thank you.
It's better, right?
Yeah,
Yeah.
thank you. It's better.
Just a minute. I will just adjust it. Now it's better, right?
Yeah, completely. It's better. Yeah.
Yeah.
Thanks.
So as I'm saying that the files have a limited range and they shape the limited area of the root canal system. And isthmuses, as you guys commonly see in the young patients, even also the uh, the age group of 20 to 35, we commonly see the isthmuses where there is no such a deposition and the pulp is obviously present there. Either it is a vital or necrotic, and it's our job to clean it. So it's the three-dimensional root canal system. And if you have a good plan of irrigation along with the activation, we can definitely clean it well. So as you guys know, this is a very famous article published on the oval shaped root canals. In oval shaped root canals, as you guys know, most of the time we use the rotary files and we just target the center and what about the corners of that oval. So in the corners, mostly debris get accumulated and that is uncleaned. And here, as you guys know, the article says 30 to 40% area is uncleaned, which really needs to shape it properly, first of all. And second, you guys need to understand that it should be cleaned well with the right and proper protocol of irrigation. If you look at the screen carefully, there are different oval shaped root canals and shaped with the different sizes of instruments. The first is, for example, shaped with the 2504, 3004, 3004, and last one, if you see, it is a 3006. So if you shape such a big canal with 3006 also, many people think that if they increase the taper, they can clean better, but it's not truth at all. Still there in the corners, you can see the tissue is got accumulated still there, and even the debris has got pushed over there. There will be the biofilms, there will be the microbes. So end of the day, we should understand it. There should be, your irrigation protocol should be proper, and if your irrigation protocol is well, you should also know about the activation. So right activation uh, can also clean it well. So you have to think about it. And most trending topic, I would like to go. Can you see the screen clearly, Ali?
Yeah,
Dr. Ali?
chemical. Yeah,
Yeah.
Yeah.
it's written chemical scouting versus
Yeah.
mechanical
Yeah.
scouting.
The trending topic is chemical scouting versus mechanical scouting. It's a big debate about it because, as you guys know, root canal system is a complex. It has lateral canals, it has portals of exits, and it has apical deltas, it has furcation canals, it has isthmus, it has anastomosis. So all these complexities cannot be cleaned with the mechanical scouting. And as you guys know, the real mechanical scouting, today I'm gonna share a few slides about the real mechanical scouting. But before that, we will just move to the chemical scouting. Chemical scouting means cleaning those microanatomies such as apical delta or lateral canals or isthmuses with the help of chemicals. Now still there is a research going on whether it gets clean or bacteria can be completely eliminated from that microstructures. But still I want to tell you, if you do your proper irrigation along with the activation, if you have good devices with you, as you guys know, we have negative pressure irrigation systems like endovac or similar, or we have different types of activation devices where you can give an energy to chemical, and that energized chemicals enters into the portals of exit and it tries to clean it. But still there is a research going on which says that the bacteria which got eliminated from the root canal microanatomies, it is quite unclear yet, but definitely in future it will be 100% clear that how the bacteria are getting eliminated from those lateral canals or microanatomies. So chemical scouting is all about cleaning those portals of exits, lateral canals, anastomosis, isthmuses with the help of irrigation and its activation. The word activation is very important here. And what about mechanical scouting? True mechanical scouting. Now I want to share first case of the chemical scouting. It's a case of maxillary second premolar where I got just a single canal which got shaped within 10 minutes, because such a straightforward canal can be shaped within 10 minutes with the right technique and modern instruments. As you guys know, I spent a quality time of irrigation, but when I obturated, I can see the multiple lateral canals and few apical deltas are also present. So such a cases can be achieved with the help of three-dimensional feel But before that 3D obturation, there should be a 3D irrigation. That is very, very important. So first of all, I always try to say the three-dimensional irrigation is also important. Cleaning in a 3D manner is very, very important before going for the 3D obturation. Yeah. Now, what is true mechanical scouting? True mechanical scouting is very, very important when you get to deal with when you deal with the enigmatic premolars. It means the premolars which have complex anatomies. For example, it is showing bifurcation, trifurcation, or quadrifurcation. In such a cases, you cannot just rely on the chemicals. This is my view. And here, if you look at the a tooth, extracted tooth, where the canal is bifurcating, especially in the apical third. So here the scouting with the manual files, that is a stainless steel file, is very, very important. When you scout those anatomies, you should be able to fill it also. That is my view. So we will directly move to the next. So what is actually the mechanical scouting? Mechanical scouting means uh, taking an entry into that accessory anatomy, such as deep apical splits, sometimes even the lateral canal, sometimes even the apical deltas, or especially the mandibular or maxillary premolars, where the one canal is getting bifurcating or trifurcating into two canals or three canals. So this is what my view is. This picture or radiographic explanation says that you can see the pre-op and post-op, and you can compare. This is what you can call it as mechanical scouting. Now we will see the case here because I want to show you in detail. So we will just zoom in. If you look, the patient came with the short obturation, pain and swelling, where I just went with the gadapacha removal. After removal of gadapacha, I scouted the two canals. I scouted two canals under microscope, which is a deep apical split. You can call it as a deep apical split. So you can see the microscopic pictures also, if you guys can see it clearly. A deep apical split has got scouted under microscope. One is buccal, one is palatal. Now, after scouting them, I just shaped with the 2004 size, and I irrigated this whole tooth very nicely. And I was not knowing also there is a third canal. Now, after irrigation, I kept the master cones in both the buccal and palatal, and I just did the hydraulic compaction. You guys can see it clearly. Because of that pressure of hydraulic compaction and three-dimensional cleaning of root canal space, the third portal, that is the third canal, can is also got filled. So this is not just because of the right obturation technique, but because also of the right irrigation protocol. So if you have right irrigation protocol with you, you can definitely clean the root canal system well, and even you can feel it. So this third canal has also got filled just because of the magic of irrigation and right obturation technique. Now, obturation technique, as you guys know, I am very much the very much popular technique, that is hot modified technique. I rely on that technique, and I personally follow the hot modified technique by Alfredo Iandolo. If anybody is interested in knowing the technique, definitely can text me. I am ready to share the PDF or the article of hot modified technique. It's very simple technique. You don't need to go into the complexity. So we'll stick to the topic, and we'll move to the next slide. Yeah. Everybody know about that. The mandibular premolars are known as enigma in endodontics. Why it is called as enigma? The meaning of enigma is very simple, that is mystery. And you know that the mystery in endodontics are mandibular first premolars. Now, why they are called as enigma? First reason, because the one canal gets bifurcated or trifurcated, especially from the middle third or in the apical third, which is very difficult to scout without magnification, first of all. Second, many people miss the another canals. They just clear the main canal, obturate main canal, and the case fails in future. So there is a case in front of you where you can see the fast break appearance. So that fast break appearance, you can see clearly the one canal is immediately got diminished. And first, how to manage this case? Many people have doubt about this, how to manage the enigmatic premolars. So first of all, whenever you get such a case, always go for the CBCT. Always. because CBCT is the only thing which is gonna give you the exact clue or idea or how many exact canals are there after the fast break appearance. So here, after CBCT, the three canals were there. So I will definitely go to the management of this. So one by one, what I did, I scouted it one by one under microscope. Because if you don't have microscope, for example, somebody, most of the people, those who have joined, might be not having microscope. Don't worry about it. Just rely on the radiograph and try to go inside and just scout one by one. Now, one main orifice, if you are using microscope of loop or any type of magnification, or those who are not using magnification, they can just see the one black hole. That is oval shaped black hole or round shaped black hole. That is the main orifice. And below that orifice at the fast break appearance level, you get the sub orifices. That is, I call them as a sub orifices. That is the small tiny holes just below the fast break appearance in the middle third or in the apical third. So that sub orifices are only visible in the microscope. You cannot see it with your naked eye, but if you don't have magnification, just go blindly and precurve your files in the directions and just count them one by one and shape them one by one. If you have a microscope, you have always a better plan because you can see that sub orifices, and that sub orifices can be scouted and can be shaped. Now in such a cases, there is really no need to show shape more. 2504, even 2004 is more than enough. I will say just stop at 2504. No need to shape more because, as you know, the root is already very tiny, thin. Okay. Now, when it comes to obturation, obturation always troubles those who don't have microscope because they exactly don't know where the gutta percha is going. Now, for those who don't have microscope, obturate one by one. Don't be in hurry and obturate. Cut at with the downpack device at the sub orifice level. Sub orifice level means below the main orifice there are tiny holes that can be called as sub orifice. So just cut one by one at sub orifice level, and remaining space you have to backfill. Okay, so this is my explanation. Now, if you have microscope or loop, if you are clearly seeing the sub orifices, cut at the sub orifices level and backfill the remaining space, where you can get such a beautiful result, and later you can give the crown, and definitely you get a better result with such a type of obturation. So managing enigma is all about, I will just summarize it, and within 5 minutes I will pass it to Dr. Ahmed. First of all, whenever you get a enigmatic cases, first of all, always go for the CBCT. If you are not taking a CBCT, you are definitely missing a lot. You will be always confused, either there are two canals or three canals. Second reason, as I said, whenever you do access opening, you get a one big round oval shape or a round shape canal where your files are just gonna go, but you don't know where they are going. So you definitely need a magnification. Third point I want to tell you, please do good flaring. If you do the good flaring, the visibility will be much better to the sub orifices if you have a microscope. Now, one by one, you have to scout it. When you scout them one by one, definitely one by one you can shape them, and if you don't have microscope, you can obturate them one by one without any fear. Now sometimes you can put your gutta percha in the wrong sub orifice or wrong canal. No need to worry, you can remove it. You have radiograph to see it, right? So those who don't have microscope, don't be fearful about it, but try to buy some type of magnification. As you guys know, Expedient is providing the good loops nowadays. At least you can buy a good loop of 5.5 or 6.5 magnification. Definitely, those who are interested in magnification can text us later. So similarly, one more case I want to show you, if you guys can see it clearly. I have a good collection of cases where I have a palatal split, especially in my region where I stay in the Maharashtra. The people, it's a rural region of Maharashtra, the birthplace of great Emperor Chhatrapati Shivaji Maharaj. Many people, those who have joined from India, already know about it. In this region, the people have very complex anatomy. As you, Dr. Ali and Dr. Ahmed, you guys can see such splits in palatal canal are You can call it as out of 100, I get 3 to 4 cases like this where the palatal canal has a split like this. Even if you guys can see one more case, so some splits are starting in just in the coronal third of the root. So it's very easy to be there in the coronal third because you can see very clearly that two orifices are there, and those two orifices can be easily scouted, shaped, and observed. But if the split is in the apical third, it becomes difficult, as you guys know. As deep it is going, it is becoming more difficult for you. So scouting them and preparing them, obturating them is really a challenge. But definitely, if you practice this art, you will always be happy and you can give a good results. You can't rely on irrigation always here because this is not a case for the. You will say that with the irrigation I can clean that split. It's impossible. You have to always shape also, irrigate also, and obturate also. So true mechanical scouting, I already explained you definitely need to learn the art of mechanical scouting, because if you don't know this art, definitely how to practice this art. Now many beginners, those who have joined, interns, or those who are learning endodontics, how to master this art. Ortho people, as you guys know, orthodontics is the big department and a big branch where most of 20 to 30% of the cases, people extract the mandibular or maxillary first premolar for the treatment. So you really get a great collection of extracted mandibular first and second premolars where you get a complex anatomy. So this complex anatomies you have to collect. At least I will say, if you are a beginner, please collect more than 30, and more than 30 mandibular premolars you have to connect, and just study the anatomy and accordingly start scouting. If you start scouting, you will understand the various types of anatomy. As you guys know, the great Marco Versiani has given more than 50 varieties of mandibular first premolar. You can get different also, because every, as you guys know, the world is so big that in every region there is a different types of anatomies. As I remember one sentence: anatomy is like a fingerprint or a snowflake. Every finger is different, same like every tooth is different. So be cautious about it. So practice this art, and definitely, after doing 10 teeth, you will definitely gain some confidence about it, and you can practice this art. Now, last 2 minutes. Hope if I have time, Dr. Ali.
Yeah. Go on. No
Yeah.
worries about the
Yeah.
time.
Yeah. So here, the next topic is secret for shaping curved canals, because curved canals is also a nightmare for all the people all around, because they don't understand how to shape curved canals. Yeah. So can you see the
Yeah,
screen clearly?
yeah. It's
Yeah.
now better. Yeah.
Yeah.
So secret for shaping curved canals. Definitely, I will just share a few ideas about it. See, only two things you have to follow. Planning, always you have to do with the zone technique, and while motion perspective, I follow two perspectives. Planning perspective, I'll always follow Dr. John Max Padden's zone technique, and when it comes to the motion perspective, I follow the TCA technique by Dr. Antonius. As you guys know, we should have a group good tools also along with us. Just this is a sequence for the CurveX file which I developed along with the Dentex India, which is we launched in the last month. It's in a pure martensitic phase and very simple protocol. Those who can take later screenshot. Anyway, so we'll directly come to the topic. As you guys know, what all things you should know whenever you are shaping the curved canals. First of all, you should be able to mark the curvature point. If you are not able to mark the curvature point in the curved canals, it will be useless. First of all, the curvature point, second, angle of curvature, third, radius of curvature, and fourth is the zones in the curvature. If you are clear with the four terminologies, definitely you can do the great management of curved canals. So as you guys know, the point from where curvature start is known as curvature point. So curvature point, as you guys can see in the picture, the C point, you can call it as the curvature point. Second, angle of curvature. There are different techniques, but I follow the Bachmann 1992. The angle which is given below here, that is an alpha, is known as angle of curvature. third radius of curvature. If anybody is interested in knowing how to draw the radius of curvature, can contact me on Instagram. I will definitely tell them. Yeah. And zones in the curvature. The point, the area above the curvature point is known as coronal zone, and the area which is below the curvature point is known as apical zone. So coronal zone should be there and apical zone should be there. You should be able to differentiate between both of them, coronal zone and apical zone. We'll directly come to the point now. These pictures are from the Dr. John McSpadden, the great Dr. John McSpadden. As you guys know, the technique is very simple. First of all, you have to, whenever you are getting a curved canal, always try to mark the curvature point. Whenever you are marking a curvature point, now, after marking a curvature point, you just have to go with number 8 C pilot or 10 C pilots, just 1 to 2 millimeter below the curvature point in an envelope motion or watch winding motion. Okay, just 1 to 2 millimeter beyond the curvature point. Do not try to capture whole canal in single attempt. That's a really bad thing. Many people are doing a mistake while shaping the curved canal. They try to go fully with number 8 or 10 till the full length, and where their file is encountering a big stress, and because of that big fatigue and big stress, that file can also separate. So here, Dr. John McSpadden's formula is very simple, reducing the stress for the next file. Simple. It's a very simple, reducing the stress for the next file. So if you look at this here, I have this simple protocol. Dr. John McSpadden says, always take working length till curvature point. So taking working length till curvature point. Second, superlose number 8 and 10 just 1 to 2 millimeter beyond the curvature point. It means, for example, working length till curvature point is 15, so you should go 16 or 17. Then you can do the coronal flaring, which I really teach in my academy to the beginners, because that is very, very important. And if you write down the advantages of coronal flaring, definitely one page will not be enough for it. So I will definitely tell you guys, those who have joined, please go and read about the coronal flaring and its advantages. Now, what tool you have to use for the coronal flaring? The tip should be inactive and the tip size should be less than 0.2 millimeter. That should not be so big. So in my opinion, I personally recommend SX by ProTaper Gold or 1508 by Curvex file or anything similar, whichever you like, you can use it. So coronal flaring should be done 0.5 millimeter short of the curvature point. So it should be 0.5 millimeter short of curvature point. Once your coronal flaring is done, believe me, your coronal zone is prepared. We will just go into the zoom. If you look at this picture here, after coronal flaring, the glide path file is introduced. Either it is a hand file or rotary file. For example, if it is a 10 number file, or if it's a glide path file 1302 or 1503. So if that glide path file, if you look at this, till the green numbers, the file is not encountering any stress. So Dr. John McSpadden always says that whatever file is inside the canal should not encounter the stress inside the canal, and engagement should be less than 6 millimeter. That is very, very important. Engagement should not be more than 6 millimeter. So if the engagement is more than 6 millimeter, there is a chances of fatigue on file and the file can separate. So whenever you want to instrument, keep in mind enough flaring is mandatory, and here coronal zone is already prepared. Now you are ready to go for the apical zone. In the same method, you can go for the apical zone, like you can go with number 10. Now you can take the full length. Biggest mistake people are doing in curved canal, directly going till an apical foramen and taking a working length. While taking working length, they struggle a lot that number 10 file is not going, number 8 file is not reaching till the apical foramen, and even they can separate their file and they can spend lot of files. I see lot of pictures of the doctors, those who have prepared a curved canal, and they show the pictures of waste number 10 or number 8 files more than 10. you know it's really a foolishness to waste lot of files. Why you need to waste lot of files? If you really want to clear the curvature with the minimum file, you should know the right technique. That's why so much I am giving so much importance to the coronal flaring, and coronal flaring is going to simplify your thing. So that's why you have to do the good coronal flaring, then go for the apical zone. Do not directly jump on the apical zone. Okay. So here I want to show the case which is given here. If you look at this case, it's a simple case actually. It's not so difficult case because it's a mandibular 7 patient came to me. I just mark the curvature points. My technique is very simple. I just mark the curvature point and I do the flaring 0.5 millimeter above the curvature point. Then only I enter into the apical zone. Okay, so initial scouting with the manual files just little bit below the curvature point, 1 or 2 millimeter, then flaring above the curvature point, then go till full length, then follow same protocol whatever you want to follow. Now uh, we'll go to the case number 2. There is one more case which is given here. Same cases as you guys can, same cases you can see on my Instagram profile also. As you guys know, in in maxillary molars, not all roots will show you the curvature, but the mesiobuccal root is always there to show you the curvatures, and those curvatures you have to manage. So keep a patience and follow the protocols which I have already shared in the previous slides. So same case, you can check the cases. Even the long, if you are getting a long roots, you can follow the zone technique always. So you can even give the mark the 2 zones. Now many people says what if there is a multiplanar curvature? If there is a multiplanar curvature, there will be 3 zones actually. Coronal zone, middle zone, and apical zone. That is a different story. Definitely, if anybody is interested in knowing about the multiplanar curvature, can definitely text me. Now, what about the cases like this, where there is the sharp hook or sharp curvature? For example, if any case you are getting such a like that, where there is a 90-degree bend or something like that, so in such a cases you should know the art of precurving. If you know the art of precurving, then only you can clear such a cases. So there are 5 types of precurving manual files. uh, for example, I will just give you the examples: long sweeping, hockey stick. Third one is the three flutes, 2 flutes, and 1 flute. Now, many people ask how you bend it. I don't have endo bender. How to bend it? I will say just with your fingers or your nails. If you have nails on your little finger or any other finger, you can do the good bending about for the 1 flute, 2 flute, or 3 flutes, or you can even precurve your with your fingers also. So it's quite easy. So just learn about the precurving, precurve your manual files, and accordingly you can scout those sharp hooks. If somebody is saying that my manual files are going but my rotary files are not going, don't worry about it. If it is less than 1 millimeter, just try to coat the sealer there and just do the warm hydraulic compaction or hot modified technique. It is definitely gonna fill. Look at the final result. In both the roots you can see almost 90-degree hooks. So such a cases can also be cleared if you are good with the technique. So conclusion, we'll directly come to the conclusion. And conclusion: understanding science of shaping, then planning and execution is key to shape any canal. Tools comes and goes, but technique stays forever. This is the message for you guys, because as you guys know, people were using Pro Taper Universal before. Now they got shifted to Trunatomy. As you guys know, people were using a lot of old files, and before that, that people were using stainless steel files with the hands. Now, as you guys know, technique is very important. That's why Dr. John Maxpellen has invented the zone technique long back. Still, this is one of the best technique to shape the curved canals. So always try to master the technique instead of falling in the gimmick of the brands, because brand comes and goes. And always be rely on the your technique. Whatever tools you are using, always rely on the technique. So this is the message for you guys. And as you guys know, this is my Instagram ID. You can see a lot of different cases, and I'm ready to discuss anytime. And once again, I want to thank Dr. Ali and Dr. Ahmed for giving me the time. Actually, I consumed a lot of time. Sorry for that. But that it's actually the never ending topic, that is an endodontics.
Yeah.
So hopefully you guys got a good message through this, and all the people those who have joined, I'm very happy that you got something to know about it. And I will pass it to Dr. Ahmed, who's going to share a very very important cases, and it will definitely help us to improve our knowledge also, and our clinical skills also. So thank you,
Thank you.
Dr. Ali, Dr. Ahmed, once again.
Thank you.
Thank you so much, Ron. Amazing cases, informative presentation. Everything was very clear on. Um, you discussed a lot of
Yeah.
tips and tricks that are very useful, and uh, we, definitely it's gonna help us in the clinic, in the practice.
Thank you. I don't want to ask a question because I want just ask Dr. Ahmad if you have any limitation about the time or not. Do you have any limitation about the time? It's fine.
No, it's fine. It's
Okay,
fine for me.
I
Yeah.
suggest you to see Dr. Ahmad cases, and then I will ask some question, and finally, if we have time, I will share my own cases. If you agree, we can go on with Dr. Ahmad cases.
Yeah.
Yeah, that
Thank you.
would be. Regarding the EndoGoat, I have this screen. It's black. I don't know how can I accept the invitation.
Did you receive my?
No,
I
I
think
haven't received
it is the
anything.
matter
I've
of
been.
actually Instagram when you open it on the laptop or Windows, because I think,
Yeah,
I think
yeah,
I want to ask you to go out of the live and then come again with the EndoGo. Let's check it again, because I think okay. Oh, you are not able to actually.
no. I've been trying to log out and log in
Yeah,
again, but
yeah.
the same issue. I cannot see presentation.
No. Let me invite you again. So I think it's not possible. Is there any problem to share the screen just on by your own page? Is it possible for you?
You mean on
No, yeah,
EndoGoat?
no, yeah. If you need to share it with EndoGoat, you can do, or you can share it with actually your private page.
I don't mind
Okay.
any of them.
Uh,
Here it's not possible through the
so do you
laptop.
have cases on your laptop?
Yes,
So go
yes.
on with your actual laptop, no problem. We can see it. Yeah, just like that. Just like the way Dr. Imran presented his cases.
Is it good like this? Can you see it, or you want me to
You
make
can
it like
make it
this?
horizontally, but you can go further by your camera and yeah, go a bit further.
Okay.
Yeah,
Okay. Can you see
it is
me now?
better. Go a bit higher that we can see the whole screen. Yeah, yeah, this is now better. Yeah, thank you.
Okay. Okay. So today I will discuss two different cases. The first one is management of calcified molar using an endo guide splint. Before I start, I would like just to give a brief introduction about the guided endodontics. There was an article by Zender. They compared teeth that were treated by using the guided endo splints and teeth without guided endo splints. Before I explain the results, let's take a look what is the guided endo splints. The picture on the left here, as we can see, this is the splint. Usually, the guided endodontic splints are used for calcified or obliterated canals. We can fabricate this splint using a software that I will show you later. But this is like an image showing the planning of the drill that we will use to get an access to the obliterated canals uh, um, according to the original location of the canal to avoid any deviation and which might result in perforation of the root. The results of this study, they found that teeth that were treated with guided endodontic splints, they had a more accurate access cavity and less perforations in comparison to the conventional technique. The interesting part about this case is that this splint was used on a molar tooth, which makes it even more challenging because of the accessibility of the drill. Usually, or most of the articles or case reports, when they use this technique, they use it on anterior teeth because usually the accessibility of molar teeth is very hard. Okay, this patient came to me with pain on the lower left area. As we can see here in the periapical X-ray, the canals were calcified, and the diagnosis according to the American Association of Endodontists was symptomatic apical periodontitis. Uh, I tried to achieve patency in those canals. I used a lot of EDTA and ultrasonic tips just to make sure that we avoid any perforation
Dr. Ahmad, can I
in the
ask
roots.
you to
Uh,
show different
yeah,
radiographs
sure.
separately? Yeah, please you zoom your camera on the actually each of the radiographs separately, yeah, and then go to show us. Yeah,
Okay,
thank you.
sure. Okay. This is the confit, and this is the obturation. So using a lot of C plus files with editor and a lot of patience, we could achieve patency in the canals. Another challenge was in this case was, as we can see here, the mandibular canal was very close to the apices, which makes it very clear, very challenging. So I decided to use bioceramic sealer to avoid any extrusion of the sealer. I used a cold obturation technique. Okay, and then I decided to do an overlay to prevent any fracture of the tooth. This is the before and after. But the problem is here, after 8 months, the patient came to me with pain. Then I took a CBCT and I found that there was a missed canal here. And I recognized that the tooth, the treatment that I did was failed. So I took a CBCT, and in the beginning I thought that this canal is the mesolingual canal, but apparently it wasn't. It was the middle mesial canal, and I was missing the mesolingual canal. So what I decided to do is a selective retreatment to preserve the overlays that I did. The selective retreatment was done using this endo-guided splint. So basically, I took a CPCT for the patient, and intraoral scan, and then I superimpose both of them together, and then I localized the exact location of the mesolingual canal. This software, which is Blue Sky, sorry, this software is usually used for implants. So here I decided to use it for my drill, which has a diameter of 0.75, which is very narrow and very small, but I decided to use it only in the coronal third of the canal, just to get an access to the missing canal, to avoid any perforation, because this drill is not flexible, just to get an access cavity, and then I will continue with the rotary files. After the planning, I placed the splint inside the patient's mouth, and then I started drilling with the drill, just until I achieved uh, um, I made sure that I entered inside the main canal, and then I placed isolation, and this is the access cavity. In this way, we preserved the recent overlay, sonic activation, and here's the obturation sequence. It's very important here when we use the guided endodontic splints. It's very important to take an X-ray on each step. Here, as we can see, this is the tip of the drill that I used, just to make sure that we are in the correct position. Even if we are using the endodontic splint, sometimes a deviation happens because it depends on the material of the splint. If we take a look at this video again, I will just show you something here. Sorry. It has like something called metal sleeve. The metal sleeve, it's like the one that we use for the implants to avoid any deviation of the file or the implant is this one. Some articles that they use this splint but without this metal sleeve. The function of this metal sleeve is to avoid any deviation. So in the studies that they used this splint without the metal sleeve, there was a lot of perforations. That's why it's very important to use this metal sleeve in accordance to the diameter of the drill that we are going to use. So for example, if the diameter of the drill is 0.75, the diameter of the metal sleeve has to be a little bit larger than the diameter of the metal sleeve by zero point 0.1 at least. So no deviation happens, and there is a space for the drill to enter inside the hole. This is the working length X-ray, and here's the obturation sequence. This is the mesolingual canal. The other one was just the middle mesial canal. Okay, that was the first case. Let's move to the second case, which is management of two separated instruments and a perforation in a premolar with three roots. Okay, this patient came to me with pain in upper left area. The tooth was previously treated. As Dr. Amran said, in complex cases, it's mandatory to take a CBST. Here we can see that the mesiobuccal and distal buccal and the palatal, all of the roots have periapical radiolucencies because of the inadequacy of the previous root canal treatments. This is a short video showing the treatment that I did here. I usually use ultrasonic tip. This is the perforation. Okay, I usually use ET25 ultrasonic tips. This is the tip that I usually use. I seal the perforation first with putty MTA. I use neo putty, and then I started in the next visit. I started to remove the two broken instruments with the ET25 from Action Company. Here's the first file, and here's the second one. That case was easy to remove the broken files. There was no need to use the grasping technique. The files were in the coronal third, as we can see here. Though this is the first file and this is the second one, but it's overlapping with the palatal root. So there was no engagement of the separated file with the canals. This is the working length, and here is the confit, and this is the obturation. Yeah, that's all. As you, because of the time, you told me to present
Thank you.
two cases. You have any questions? I'm all ears.
Thank you. Thank you. It was a great presentation. It was very informative. Thanks for sharing your interesting, amazing cases. I really enjoyed the case you have shared. Okay, if you let me, I will ask you some question about the cases you have shared. First of all, I want to start with Dr. Imran cases. I want to ask you in which step do you look for extra canals? Because we have different concepts. Some concepts say that you have to find, for example, if you have deep split, you have find any actually separation at deep split first when you want to actually shape the canals. But some concepts say that you can look for extra canals at the end of your treatment. But there are some concerns that you may push and some debris at the orifices or at the level of the separation, and you are not going to be able to negotiate or scout the
Yeah,
canals. I want to
yeah,
you
yeah,
to
definitely.
tell me your concepts.
See, I will really simplify it. First of all, see, whenever you get an enigmatic premolar or a complex mandibular premolar or even a maxillary premolar, definitely I always go with the easiest canal first, easiest one. Yeah, and I always try to go with the easiest canal first. And if there are two canals, as you guys know, it's very simple case. If the mandibular premolar has only two canals, one canal is only bifurcating, means there will be one buccal and one lingual. So both the canals are very simple. But if there are three canals, that really makes it challenging. So out of three canals, one canal will be very simple. That is most of the time is lingual, most of the time, because
Yeah.
the tooth will have two buccal canals and one lingual canals, which is quite common. But sometimes that will be opposite of it. There will be two small lingual canals and one buccal canal. So always go with the easier and wider one. As you guys know, I don't shape the difficult canals first. I always go with the easier one and I shape it fast, then I scout the others. I do not go with difficult first. And if I have a microscope and I am able to see all the tiny holes, that tiny holes I definitely shape, and one by one I just flare also little bit with the glide path files. Especially a 1503 file is my favorite after 10. And after 10, 1503 I really like, because this works very well. Dr. Ahmed will explain about his favorite glide path file. I don't know what size glide path file is using. I just use two glide path files. One is 1302 and another one is 1503. Not in routine cases, I directly go after 10. I 10 number hand file. I directly go with 1503, and after in complex cases, sometimes I use 1302 file also.
For me, I use a glide path from a Brazilian company. It's
Yeah.
called Univi. They have a glide path. It's very small. It's
Yeah.
one of the smallest. It's 10.03, which is almost the same
Okay.
as the manual
Okay.
files.
Okay. So, what is Doctor?
Yeah,
It's a question from my side to Dr. Ahmed. What is your view on the manual-less instrumentation in upcoming future?
manual
Manual-less,
instrumentation using.
manual-less.
Sorry,
Yeah.
I didn't
I
hear
think
you.
that Dr. Imran talks about the manual preparation of the
No.
root canal system
No.
with K files. Yeah,
No. Yeah.
with hand
No
files.
K
Yeah.
file. Nothing. No hand files. Only rotary files.
Yeah.
Only rotary files. I think it's a promising approach. Um, in my opinion, size 10 is we cannot exempt it. I think we'll keep using it. Um, but I think in the future they are now fabricating smaller sizes. I think in the future we will just keep using rotary files with
Yeah.
patency files.
I want to just mention three different terminology that we have in the field of endodontics. We have canal scouting, canal negotiation, and canal glide path. In my actual
Mhm,
practice, I use a small K file, for example, 6, 8, 10, to just negotiate, and
mhm,
canal scouting to see the curvature, different actually angles of curvature that the canals have. I do not use K files to prepare the canal or actually to prepare glide paths, but I want to see what's happening in the canals, because when you put your file into the root canal system and then you withdraw it from the root canal system, you will see the different
Yeah.
curvatures that in the files because of its shape memory. And I will understand the actually 3D anatomy of the root canal system, because we see only a 2D radiograph, for example, preapical radiograph, especially if we don't have
Yeah.
any CBCT about the canal. So in my concept, I use small K files to see the anatomy of the root canal system, and it will help me what is going to be happen in the future and what's the type of the root canal system I'm going to deal with.
Yeah. One more question for Dr. Ahmed and Dr. Ali. What techniques do you guys prefer? Oh, sorry. What motion do you guys prefer while shaping a canals? Like a pecking motion, or brushing motion, or one stroke clean, or TCA technique?
Dr. Ahmad, go on.
Yeah, for me, I use picking motion. Uh, this is the most commonly used for me. Um, Sometimes when I use sometimes I use reciprocating motion and sometimes rotation motion. But as you know, studies have shown that there are no significant differences on them. But in my opinion, reciprocation is safer than
Yeah.
rotation, as you know, because of the less
Exactly.
cyclic fatigue. Uh, yeah. Anyway, I think at the end it's the the metallurgy is more
Exactly.
important factor than the color.
Exactly.
Sorry.
What kind of, yeah.
Okay, actually, in many cases, I use picking motion in a crown down manner, as you have talked about the zone technique by Dr. Max Spadden. But I really like the technique which is called arithmetic crown down tactile control activation technique.
Yeah.
We have an article, yeah, that there was a case, and the curvature is like a S word, and we call the Bionet curve, and we can use arithmetic crown down tactile control activation technique. It is the
Exactly.
combination of zone technique and TCA technique, and I
Exactly.
really like that technique because first you go for the coronal part and you prepare your coronal zone completely, and then you
Exactly.
will go for the apical zone by the TCA technique. TCA technique, I think, is a very safe technique that will help you to lower your fracture rate of your
Exactly.
rotary instrument. But
Yeah.
we should consider that this technique is actually designed for rotary systems. If we have reciprocating system, I think it is not possible to use TCA or arithmetic round down TCA technique. It is only designed for rotary files, but it is a very safe technique. And
Yeah.
I really suggest to use this technique if you have rotary files. But we should consider that we have Martin seat file because austenite files are not suitable for managing very severe curvature and the curvature like that.
Exactly. Yeah. So the last question from my side is, uh, what technique you commonly use for the obturation along with which sealer? Means which sealers you guys prefer along with obturation? Which obturation technique?
Okay, for me, I usually use for straight canals, I use Max Padden. I use the thermomechanical
Okay.
compaction technique. Um, in curved canals, I use bioceramic
Okay.
sealers.
Uh,
Yeah. And you?
in many cases, because I work in different clinics in my city, and there are no actually dental operating microscope in every clinics that I work. So when I don't have a dental operating microscope, I prefer to use a lateral compaction technique. I use a lateral compaction technique, but if I have a dental operating microscope, I will go for actually continuous wave compaction by Dr. Buchanan because it is very easier when you have magnification. You can see the exact point that you will cut the gutta in the root canal system, and you can easily use thermoplastic gutta to fill the coronal part of the tooth. I'm not actually technique dependent. I use different techniques for different situations. I will use, for example, I use bioceramic sealer if I have do not if the access cavity is not easy for me to use lateral compaction or continuous wave compaction. I will go for bioceramic sealers because it make the obturation technique easier. It depends on the situation and depends on
Yeah.
the patient. It depends on the time and depends on the actually case by case decision.
Thank you.
And you, Dr. which obturation technique do you usually use?
I usually use a hot modified technique. Actually, it's the same like warm hydraulic compaction. Warm hydraulic compaction means
Mhm.
just creating a hydraulic pressure 3 to 4 millimeter below the orifice by using a downpack device and heat carrier. And because of that, the hydraulic pressure gets act on the sealer. Whatever sealer you're using, either you're using a bioceramic or resin based or anything. In bioceramic, just keep in mind, if you want to create a hydraulic pressure on sealer, you have to lower the temperature of the downpack device. It should be 150 degrees Celsius. But with the resin based sealer, you can directly go with the 200, 250, 300. Just go 2 to 3 millimeter below the orifice, create a hydraulic pressure. If you have a true tuck back, and definitely your sealer is gonna go into the anatomies for sure. That is for sure. and that is the best way, in my opinion, to feel those anatomies, lateral canals, portals of exit. So I mostly rely on the hot modified technique, or you can, another name for that is warm hydraulic compaction. So it's a simple thing.
Very good. I just want to mention an article written by Dr. Domenico Ricucci about the sealer extrusion and
Yeah,
about the filling of the lateral or accessory canals. In that article, it was said that it was indicated that there's no actually we are not
yeah,
mandatory to
yeah.
fill
See,
those
yeah,
areas because we are not able to completely disinfect it. And if you're obturated, those
exactly.
lateral canals, it doesn't mean that they are
Yeah,
completely disinfected, and there is
in,
no
in
necessity to complete those
yeah,
areas. But when you see that those areas are filled, you can be happy because it may show that you were able to completely to somehow disinfect those canals. But it is not mandatory to completely fill
exactly.
those areas based on the article published by Dr. Ricucci.
Yeah, yeah.
Exactly.
I have a view on this. I have gone through that article of Domenico Ricusi, and as he says, it's quite impossible to disinfect those lateral anatomies and microanatomies.
Mm.
But you know what? Still, the research is going on. I think in another 15 year we can get research something like that, whether there are microbes or not. So hopefully,
Yeah,
I am so much my view is on the thing as if you are really using a great devices and you are dedicated and passionate about the root canal cleanings. In my opinion, you can reach till the 90% of the bacterial or biofilm removal. As you guys know, we just rely on the imaginary world that we have cleaned the canal, but still there are some amount of tissue and microbes which are getting mummifying inside the root canal system. So that is obviously mummifying. Still, we need great devices. As I have seen, you have done Instagram live with the Dr. Mustafa, and he was talking about the device by
exactly.
Sonendo.
Yeah,
Yeah,
gentleman
and I
system.
need more devices in another. I think till 2030 we get something like that. So in future, hopefully, we can clean it well automatically without giving a lot of effort.
Yeah, exactly. That's why I don't emphasize on actually obturation technique because there was a quotation by Dr. Wayne, and it was said that what you put out of the canal is more important than what you put inside the canal. And I
Exactly.
think that's the main principle of the endodontic treatment. You have to disinfect the root canal system as much as possible. It is way important than how you fill the root canal system because when you have bacteria and there are large amounts of bacteria inside the root canal system. If you obturate it completely and in the 3D dimensions, you still have the chance of failure of your treatment. So putting emphasis on the disinfection of the root canal system, specifically the chemical disinfection of the root canal system is way important than on the technique of the filling of the root canal system.
Exactly, exactly. That's true.
Yeah,
Yeah.
yeah,
Okay, I really enjoyed the case that Dr. Ahmad shared about the endo guide, and I
Yeah.
was very actually amazed and somehow surprised how he managed the case perfectly. I just want to ask you a question about the drill and the size of the drill that you use, because as you know, when we use endo guide, we may use larger burrs to reach the root canal system, and it will make the tooth weak. I want to ask about the size of the drill and said about the, for example, brand, if you can say it us.
sure, sure. Okay, this is I've looked at the market, and this is the smallest size that I found. Okay, the diameter of it is 0.75. Okay, and it's a French company called Thomas. I can
Thank
share
you.
it with you. Okay, yeah, because yeah, correct. As you said, most of the studies, the diameter was more
Exactly.
than 1 millimeter, which is not. exactly, which is not applicable, especially in molars. If we are talking about upper centrals, yes, we can do it. That's why in most of the cases or case reports, they discuss it or they try it on upper centrals. First of all, the accessibility is easy. Okay, on upper or front teeth, it's very easy to do it. But I was lucky, to be honest, on the molar. Also, the tooth was tilted. Okay, that made it a little bit easier. Okay, I could get an access to the tooth, and also thankfully it was
This
mesial canal,
exactly.
not a distal canal. It would make it
Yeah,
even harder.
I really enjoyed your case, and I'm
Yeah,
going to do such
I
treatment on the same situations. I will try that. Thank you. Thanks for sharing
I
your
want to
knowledge.
comment on I want to comment on Dr. Ahmed's case. I have seen it first time that somebody is taking such a small access from the overlay and exactly targeting the calcified canal and even clearing it without any hesitation and problem. It's really great, and I would really like to read the article, even the chapter which you have recently contributed to the book. Definitely, I'll order that book also. It will be a great pleasure to
Yeah.
have you guys and Dr. Ahmed, and really inspired from both of you, and learn many things from Dr. Ahmed today. In two cases, he has spoke 200 lines, I can say, because there are a lot of learning in each and everything. Because preparing such a great guide, which is exactly guiding you and leaving you till the point, it's not easy. Because most of the time we get a retreatment cases and we struggle
No.
like anything. We remove the crown, we remove everything, then we search, then we find it's really difficult. Hopefully this research is going to definitely help to everybody, those who have given a zirconia crowns in future and don't want to remove it.
Yeah,
Thank you
yeah.
so much. Thank you
It
so
was.
much for those words.
Yeah, go on.
Yeah. Same for me. I learned a lot from your cases, your tips and tricks. You discussed like daily cases and also rare cases. It was very useful from all the aspects. Regarding the endo-guided case, hopefully it will. Now I am working to publish it. Once I publish it, I will be very pleased to
Thank you
Thank
share
so
it
you.
with you.
much.
Thank you. Okay, if you
Thank you.
agree, I
Thank you.
will go to share my own cases very fast
Yeah.
to use the time, and
Yeah.
then we will finish the actually session. Okay, let me
Okay.
go.
Okay.
Uh,
Yeah, eagerly waiting to see.
Yeah.
uh, uh, I just want to express my gratitude and thankfulness to all the endodontists that accept our invitation. We have gathered a great, esteemed, actually endodontists all around the world, and our team and our community. I am sure it will going to be bigger and bigger and bigger in the near future. And we are in the first phase of the Endo Leaders Show, and we are going, and we hope that we can have other phases of Endo Leaders Show. The first case I want to share you is the right central incisor in the mandible that was referred to me for the endodontic treatment. As all of us know, the central and lateral incisor in the mandible are very tricky. We may face different challenges. Actually have, we may have two canals at the one at the central and lateral incisor in the mandible. As you can see, when I prepared the root canal system, here I want to magnify the radiograph. You can, if I can, yeah, if you see there is a deviation and uncentrality of the gutta percha in the root canal system. If you just actually rely on this radiograph, you may say that we have type 2 vertebrae root canal system. But I was suspected of another apical foramen when I see this radiograph. So I went for negotiating more and more to find another apical foramen. And finally, I was able to completely obturate this root canal system. And you can see at the final radiograph, we have two apical foramen. And the real type of the root canal system is type 6 Vertoci. And this type of root canal system is really hard to be find and negotiated, because many clinicians may think that they have faced the type 2 Vertoci, but when you negotiate the root canal system from different actually apical split and apical area, you will see that you have two apical foramen. And I use lateral compaction technique to obturate this root canal system. Many think that the only way to obturate this root canal system is to use a one vertical compaction. But I want to say and mention that if you are able to negotiate all the root canal system and all the separation at the apical area with your K5s and with your actual rotary 5s, you can be able to obturate the root canal system with lateral compaction technique. I will talk about my technique with lateral compaction technique and how I obturate these anatomies in my daily practice. And the second case is this case. Let me go a bit higher. Okay. When this case was referred to me, I thought that I'm going to deal with mandibular premolar with 3 root canal system, and I was suspected of negotiating 3 different root canal systems. And this is the photograph of the clinical area of the root canal system. And after I prepared my access cavity, as you can see, I was searched for different canals. Specifically at the buccal area, I was looking for mesiobuccal, discobuccal, and lingual canals. And when I took a radiograph, I thought that there was only 2 canals at the root canal system. But because of the initial radiograph, I thought that I was at the verge of missing a canal that I wasn't able to negotiate and find. So I ordered an intraoperative CBCT for this case. Let's see this CBCT. Look at this area. This was the tooth that I was going to treat. As you can see, we have only one buccal and lingual canal, but the main anatomy of the root canal system was a C-type mandibular premolar. As you know, based on many articles, the normal variation the first mandibular premolar is a 3-rooted tooth, but the second mandibular premolar, which was the case I was treating, was just a C-type mandibular premolar with 2 apical foramen and 2 root canal system at the end of the anatomy. So I was confirmed, and I was actually completely confident about the root canal system. So I went for the obturation. And this was the final obturation. And I was sharing this case, and I want to mention that the CBCT is a big help to managing complex anatomies and complex actually cases, because based on a joint position statement by ESE and AAE, we can order CBCT for managing complex cases. There was a concern about the amount of the X-ray that we may face, but today we know that the X-ray and the actually the side effect of the CBCT is program, and I'm going to tell you that our third program is going to be happen on 25th September. So join us to have a great discussion about the single cone technique with BC sealers, a myth or a paradigm shift. We will talk about the latest technique of obturation, which is bioceramic sealers. Okay, let me back to my front camera. Okay, that was the two cases I want to share about you. I'm going to talk about the way that I'm operating the Type 6 Vertucci. As you know, when you place a gutta percha, for example, you have buccal and lingual canal, as the case I have shared. When you put your gutta percha from the buccal canal, and when you put another gutta percha from the lingual canal, they will meet each other, and the buccal gutta percha will not let your lingual gutta percha to completely pass the separation area. In this situation, actually, I use a spreader size 25 or 30 from the lingual canal, and I put my spreader from the lingual canal to the working length. I don't actually put my and negotiate my spreader to, for example, 1 or 2 millimeters from my working length. In this case, actually, I use in this situation, I use accessory cones to fill the apical separation area. And then I will go to completely obturate the lingual canal from the buccal orifices with the lateral compaction technique, or, for example, by continuous wave compaction technique. But I just want to mention that we can obturate the Type 6 Vertucci root canal system with lateral compaction technique, as I mentioned and I told you. Okay, if you have any question.
What do you think about, what do you think about using bioceramic sealers in such cases?
Yeah.
If we have Vertucci, would you consider using?
My main concern about using bioceramic sealer in this situation, I prefer to have gutta percha from the coronal part to the apical area completely. Because about the retreatment cases, as we know, we have some troubles and challenges if we want to retreatment these cases. If we have gutta percha at the root canal system from the coronal area to the apical area, it is easier to have retreatment in case in the future, in any situation we have in the future. So if I want to use bioceramic sealer to obturate these types of canals, I prefer to be to sure that I can put my gutta percha from the lingual and buccal area to the apical area in the split area completely. I don't prefer to obturate those areas with just sealers.
Okay. Okay.
What is your idea and what is your technique to obturate these complex anatomies?
I prefer my technique in those complex anatomies is to use like system B, okay. But for example, if the apical part of the canal is not reachable, okay, I would think about sealing it with bioceramic sealer.
Yeah, for unnegotiable canals, the BC sealers and one vertical obturation technique is a good choice, because you may be able to fill those canals because of the actual flowability of your sealer or your gutta percha. But if you're able to negotiate those canals with your hand files and your rotary files, you can be able to obturate it completely with gutta percha.
Exactly, yes.
Okay. Thank you.
Thank you so much for that. This is very nice cases.
Thank you. Ali,
Thank
for the beautiful explanation about the challenging premolar and C-shaped root canal obturation techniques.
Yeah, thanks. I really enjoyed your cases. And I want to ask you my final question about ordering CBCT in your daily practice. How often do you order CBCT for your cases,
Whenever,
specifically when you want
whenever I
to
see,
deal with challenging anatomy?
yeah, whenever I see that the case is, I am not able to read the case, especially the reading case with radiograph is sometimes become challenging, especially for example, it's a simple trick. After troughing, we'll take an example of maxillary molar, where I'm not able to find MB2 even after troughing, right? And after giving an angulated radiograph also, I'm not able to see it. So I simply just ask the patient to go to CBCT whether there is MB2 or not. Second, whether I'm confused that in a retreatment case, whether there is a vertical root fracture or is there any perforation or something like that. Especially in retreatment cases, I send the patient to CBCT center. And when it comes to complex anatomy, whenever I'm confused about the anatomy, I go for the CBCT center. I send the patient to CBCT center because I don't have in-house CBCT. So definitely patient go to CBCT center and they bring the reports.
yeah. Same for me. And according to the position statement that Dr. Ali mentioned, the position statement of the they mentioned the exact cases that Dr. Amran mentioned, and also in cases of resorption, complex anatomy cases, calcified patients, most of retreatment cases would require a CBCT.
Even when I see the big lesion, I am not able to guess what is the big, what is the like how much it will measure and what will be the length and width of that lesion. So it's quite mandatory to understand because if you start a big lesion cases non-surgically immediately, the lesion will not get treated non-surgically sometimes. So definitely you need a CBCT in the lesion cases also. That is very important.
Yeah, correct. Also, in addition to that, in cases of apical surgery,
Exactly.
if if the lesion is close to vital structures like the maxillary sinus or the nasal floor or the nerve, it's going to be very crucial to do CBCT to avoid any complications.
Yes, in a chapter that you have written, I read that you mentioned that the author suggested that to order CBCT for every cases when you want to do microsurgical endodontics. In that
Yeah,
book, I think you are the first one in the world that actually suggests ordering CBCT for every cases in the field of microsurgical endodontics.
yeah, exactly. It's for many reasons. First of all, see the exact reason of the failure, and also to avoid any complications, or if there is any edemases or missed canal or any anatomical structures that you need to avoid during the procedure, it's mandatory to take
Exactly.
CPCT.
Because I think the main reason of ordering CBCT is to see the reason of the previous failure of the root canal system. Because when we look at many
Yeah,
radiographs, we cannot guess or actually clear the reason behind the failure. But CBCT will show many details that we are not able to see by a 2D radiograph.
exactly, yes.
Very good. Okay. Thank you, my friends. I think our session take a long, but it was very interesting, and I was very amazed about the cases, about the discussion we have, and I just want to thank you about the dedication and your efforts towards the show. You have prepared the very good cases for this show, and I think all the audiences have learned a lot about these cases and about the knowledge that you have shared with us. Thank you. We hope to see you
Thank
again in the
you so much.
future programs. Yeah.
Yeah, thank you so much, Dr. Ali, for inviting. And definitely, it was a pleasure to be with you guys. And as I said, in India, we consider those who visit the India, we consider them as a god. It's a saying that Atithi Devo Bhava in India. It means the visitors are most welcome in India. And I would like to definitely invite Dr. Ali, Dr. Ahmed. You guys are most welcome to this beautiful country. And hopefully in future you will come to India for either for any congress to meet me or anything. You are most welcome. Definitely, guys. And I am pleasure, and it's my blessing to the Endo Leaders Show. This hopefully this show will become the world's one of the best show where you can start even a podcast also with the big Endo legends in future. Definitely.
Thank you. It cannot be possible without the help of the esteemed endodontists like you. We are all in one boat and we are all in one community. We together can actually promote this group. Thank you.
Okay. Thank you. Mr. Reed.
Thanks to you.
Okay.
Thank you so much for your cases
Thank you.
and for the
Thank
invitation.
Thanks for thank you. Thanks for everything.
thank
I want to actually finish this session, and I hope to see you soon again with more interesting subject and actually programs.
Okay. Thank you, Dr. Ali. Have a good day. Have a great good night. Good night, Dr. Ahmed. Good night, Dr. Ali. Bye bye.
Good
Take
night.
care.
Good
Bye.
night, my friends. Good night. Have a nice night. Thank you.